Dr. Samuel dos Santos Ribeiro from Belgium. He is a consultant at fertility diagnostic, genetics, and immunology at the University of Zwijndrecht in Brussels. I hope I pronounced it correctly. And he is going to give a talk on freeze-all, better pregnancy rate, or just a matter of safety. Thank you.
Thank you very much for this very kind presentation. I see that today I'm not the first one to be a new job in a new time, because just literally I followed my love and my partner, and I've been starting to work in Lisbon since Monday. So the research continues, but I'm no longer in Brussels since Monday. But I still do want to talk to you about a very big topic and hot topic that excites me a lot. And there's been the sense of the research that I've been doing until now, and the group that we've been doing in Brussels regarding endometrial receptivity and ovarian stimulation. First of all, to show you the financial disclosures that I have, and going on, talking about why are we here today. And a lot has happened indeed since the 1980s, where we had the first embryo transfer done frozen, until nowadays. And from then, the first thing that we were talking about was always about safety. And this very interesting paper that came from our former boss, Professor De Vrooy, called the OHSS Free Clinic, was what really launched the freeze-all concept, and which really coined the freeze-all concept, which was freezing everything in terms of safety. However, what I will be discussing with you today is what happened after that. The conversion for this freeze-for-all versus freeze-all debate, and to try and understand a little bit more what came in between to make many clinics decide to go to at least freeze-for-more, and some of them freeze-for-all. There are some spoilers here. It had to do with twinning, it had to do with safety, with time it had to do with pregnancy outcomes, and some have also been showing better neonatal outcomes, just like Professor Bragg has shown. However, I want to check each of these topics with you, and especially the last two topics, to see what is the clinical evidence about this, and a little bit more to look at the question that I show you now. Because at this moment, we're in a standstill in which we can go one way or the other, and I want to discuss why some are saying that the grass is greener on another side. I will be talking to you about the potential benefits about freezing for more patients, not only the OHSS free clinic, the safety issue, but also potentially better live birth outcomes and neonatal outcomes. But I also want to discuss, moreover, looking at the risks as things that could be concerning for us, and also try to imagine what a world with freeze for more or freeze all could be about, and what it could entail for both patients and clinicians. Now, I need to talk about this because this is the main reason why freeze-all existed. It had to do with safety. And these are the numbers that I'm going to show you when you look at OHSS after agonist triggering in an antagonist cycle. And what you will notice is a whole lot of zeros on this side. And it's very interesting to see that all RCTs show that indeed moderate to severe OHSS is severely decreased when you perform agonist triggering. And the nice thing that you like to see in research is when your observational data agrees with your prospective data. And this is one of the few cases in which this happens so strong and so well. Only 7 cases of OHSS has been described. However, this has caused some people, and I would like to caution us, to do something which is now called wild stimulation. Let's give 300 units of whatever drug we like, and give it to all. The more eggs, the better. And it's nice to have George here, because for some reason, every time I show this slide, George is here. And why is it here? Griesinger was the first one to say, look, I had one case of ovarian hyperstimulation syndrome after freeze-all. And he was really criticized. You have no idea what you're doing. It's a hematoma. There was no bleeding. It was not OHSS. And then another 6 cases came out. And then people started saying, no, but these people are all genetic freaks. You will never have it in your clinic. So we got the 7th case. And unfortunately, we did have the seventh case of a patient that had a very high response. And since we thought, okay, she is a genetic freak, we did whole genome sequencing, and we found nothing. So at this moment, we don't know why, once in a while, a patient will have ovarian hyperstimulation syndrome despite performing a freeze-all protocol. We have tried to collect the genetic content, and we now have 4 of the 7 patients. We have their genetic content. We're going to do whole genome sequencing. We've done it, and the publication is coming out very soon. We hope in Molecular Human Reproduction. But for now, I can give you a little spoiler. It doesn't seem like there's a reason which you can avoid or a test you can do to everyone. However, let's go back beyond, or let's go forward beyond safety. Let's talk about how efficient you can be. And now, I'm not going to dwell too much on this. Nick spoke about it a lot. There's no need for me to be speaking about it a lot. But basically, most of the drugs that we give affect in some way endometrial receptivity. And the most thing that we're concerned about is the effect that they have on the secretion, the supraphysiological secretion of both estradiol and progesterone. Also, ACG that you give also seems to be detrimental for the endometrium. So basically, it's this whole mixture of things that are toxic, either to the endometrium or to the embryo when it's trying to implant. Now, looking specifically at just pregnancy rates, these results, some of them have already been presented today. I'm just going to divide them into normal and high responders. And when you look at the patients that are normal responders, and in some cases this mixes not specifically normal response, but ovulatory response, like it's been shown by Professor Berg before, you see that in fact, except for Shapiro, the results seem to show, and especially these 2 new studies, which are very big and very robust, seem to show that it's not that much better in a normal responder that doesn't have that many hormones circulating to perform a freeze-all protocol. So going freeze for all, going for everyone, maybe it doesn't make sense nowadays. In the high responders, there was some more controversy. And as you see here, there were 2 studies before very recently, and one of them was saying it's very good, go for it, and the other one was saying, well, they both perform well, maybe you don't really need to do it. The issue and the controversy came from the fact that one of these studies was retracted due to what was considered to be serious statistical mistakes. Fortunately, Chen published recently in New England an interesting study showing that indeed freeze-all in patients with high response and high circulating number of hormones, pregnancies are indeed much better. It seemed that the pregnancy rates were better due to a decrease in miscarriage rates. There was one big problem, though, is that they forgot the main reason for freeze-all, which is safety. You don't give ACG triggering to a high responder patient. So, for that reason, there's one trial that we developed and that we have recently concluded, which is the ICE trial. I'm not going to spoil you the results here. I hope you see you all in ESHRE to show you what the results were. However, I do want to show you some indirect evidence. And this is the registry data coming from the United States, in which from before the results were showed together, freeze versus fresh, and from 2010, they separated it. And you see that while the fresh outcomes still remain stable after the years, the frozen increased and increased and increased. For some reason, when this publication came out in Fertility and Sterility, this wasn't a big issue. Nobody really looked at this graph or cared. Something happened. Was it vitrification? Is it PGS 2.0? Is it because we're looking at our endometria? I don't know what is going on, but the fact is you have room for improvement in frozen embryo transfers, which you don't seem to be having in the last years for fresh embryo transfer. There are some other things I want to talk to you about, especially for the clinicians in the house. It seemed, and there was a lot of evidence to show that ovarian stimulation caused some irregular contractility to your uterus and also affected negatively the endometrium inside the uterus, so that maybe that would be indirectly increasing the chances of having implantations outside. I want to show you some results that come from the States and the UK that was published by our group. And it doesn't seem that it's exactly that case. What seems, at least with the UK data, is that ectopic pregnancy decreased over time for both frozen embryo transfers and fresh embryo transfers. And in both the adjusted and unadjusted analysis, the ectopic pregnancy rate did not seem to change that much when you performed a frozen embryo transfer. When you look at the US data, there's something that is very strange. It is the green line that I'm trying to show you. Those are the frozen embryos. Something happened in 2003 that when you look at it linearly, it's going to give you a positive decrease. But what actually happens is after 2003, you have a more or less stable ectopic pregnancy rate. So when we're looking at other things beyond clinical pregnancy rate and live birth rate, doesn't seem that the ectopic pregnancy information that we used to tell our patients is that robust as we would think. There are, however, some interesting neonatal data that I have purposely reduced after seeing that Christina presented them. The consistent benefits that we had was lower prematurity and lower small for gestational age or low birth weight children. There are less consistent finding those, some being of having more, similar, or even less perinatal or neonatal death. And another recent study coming from our group showing that there are lower monozygotic rates when you perform frozen embryo transfer. These are some additional potential benefits. I also want to talk to you about some bonus benefits when you think about freeze for more patients or freezing for it more and more in your population. And one of this is cost effectiveness. There are not that many studies looking into it. One were just looked at the direct costs and showed that it was equivalent. Meantime, the other one looked at the miscarriage costs plus the direct costs, and it seems that freeze-all in that expense was superior. The issue I have is when you factor in the previous slide with the slide that comes after. And that's why I believe that it will be very important, because the majority of the costs associated to IVF comes with the complications that we cause later on with the neonatal morbidity. There's something else I would like to show you, and I would have loved to show the slide by the study by Dr. Lattes, because as chairperson it would have been interesting. Unfortunately, she doesn't have an image, so it's much easier to show one that has an image. However, it's talking about to delay or not to delay a frozen embryo transfer after freeze-all. Indeed, this was the first major issue with the freeze-all protocol, which is every single patient wants to be pregnant yesterday. And most importantly, the first trials that were coming out always encouraged patients to wait 1, 2, or even 3 months to perform the frozen embryo transfer cycle. Fortunately, and that we see now by the number of studies coming out, Brussels and other centers have a big pressure from their patients, especially with short-term visas, to perform immediate embryo transfers. So we compared patients with an immediate embryo transfer in the immediate cycle afterwards, they menstruate 5 to 7 days after, or those that waited at least 1 menstrual cycle. We didn't have enough data by ourselves, so we joined forces with Vietnam, and with the results that come from Dr. Lan show that if you perform an immediate or delayed transfer, it's the same. You won't have any issue whatsoever, regardless if you live in Belgium, if you live in Vietnam, if you're doing it for freeze-all because of OHSS, of high progesterone, regardless of your indication, pregnancy rates are as good or maybe a little even better when you perform it immediately. Dr. Lattes, importantly, has shown that this is true in live births, so it's even more robust data. However, let's talk beyond pregnancy rates, because patients don't only look at that, and safety is something that doesn't happen very often when it comes. Not all our patients are high responders. Are there other indications for you to freeze all? I'm not going to give you each one of them in very big detail, but I do want to discuss these 3. Elevated progesterone, those that are poor responders, and patients with recurrent implantation failure. When it comes to late follicular elevated progesterone, I show you 2 studies. This one showing from Healy showing that when you perform a transfer in a freeze-all protocol, your pregnancy rates seem to be increased. And consistently, it's shown also here that regardless of your age, if your progesterone is higher than 1, performing a freeze-only protocol is better than performing a fresh embryo transfer. I do, however, want to come back to this wild stimulation issue, Because many people talk about the fact that if freeze-all gives you less problems with ovarian hyperstimulation, okay, maybe I will have the 8th case in my center, but all the other patients will be pregnant. Progesterone can also be cured by freeze-all, so why again, let's not give all 300 units to all our patients. And yeah, I want to show you a study that our group published last month, looking at embryo utilization after a cycle according to the progesterone you had on the day of triggering. And we divided, for institutional reasons, we divided in low, medium, and high. And something that you note, which for us is very interesting, is high patients with high progesterone will have lower utilization rates, regardless if you're doing a transfer on day 3 or day 5. And most importantly, there is a repercussion on the cumulative live birth rates when this occurs. The curve of increase that you have, regardless if you have 1 egg, 10 eggs, 15, or even more, the curve of increase of your cumulative live birth rates isn't as steep as you would expect with those with low or normal progesterone. So again, please, I know that stimulation and having more eggs is encouraging, and it probably will increase your cumulative birth rates, but progesterone and the way that you're stimulating your eggs too much might be an issue. Going back to freeze-all for poor responders, this is something that was hyped a lot because these patients are given a lot of stimulation, and 2, are frequently and imminently exhausting their cohorts. And these are the patients that normally have a high progesterone. So people thought, okay, endometrial receptivity here will be enhanced by a freeze-all protocol. There are new studies in the pipeline, but the studies that exist thus far show these results. One coming from Roche showing no benefit whatsoever, 30% pregnancy rates, and then another study coming from Shu showing an increase, especially in the per-embryo transfer protocol, of 7%. And yeah, we need to acknowledge that it was a relatively small sample size. So maybe the detection was not found just due to sheer size and sheer numbers. Going to our last cohorts, and now I would call to your attention again that thus far, it's all about looking to the future. We need more and more robust studies, but these are just indicators of the results that we might find. And this one comes to patients with recurrent implantation failure, our biggest black box, the black box that will occupy Nick Maklong until his retirement, the very difficult patients that we can't resolve and that we can't even define. The main issue here is that the definition was after 3 transfers or 3 failed cycles of 4 embryos or more. But what is interesting to find here is that the freeze-all group seemed to perform better, significantly better in both the per cycle and per embryo transfer analysis. I've talked to you about all the great things to freeze-all, but now I want to talk to you about the problems. These are the main issues that have been associated, and some of them Professor Berg has already talked about. So I'm going to ignore 2 of them, and those that are the ones that are mostly associated to parity as well. So if you've had a child before and then do a frozen embryo transfer, it's more likely that you're going to have more C-sections because you likely had a C-section before. The one I want to concentrate is the one that we're most concerned about, which is macrosomia and the large for gestational age children. And there are too many studies talking about this. This is once again a result that is not inconsistent. Everybody is talking about it. Though, however, I'm only going to show you one study because I think it's the one that shows the most important variable, which is using birth weight Z-scores. If you look just less than 1.5 kilos, less than 2.5, although it's clinically easy to interpret, statistically you're forgetting that the baby has either a male or female sex, and that the gestational age that he is born with is very important to determine this difference. So it's more powerful when you do these analyses using Z-scores. However, even when you look at Z-scores, frozen embryos give you more heavy babies, regardless if it's after a fresh cycle, after a frozen cycle, regardless of what kind of parity the couple has. And the main concern that this gives us, I apologize for the fact that it's unformatted, but the main concern people have is not so much that the baby is a bit heavier, but it's a consequence that you will have afterwards. Will these children have more diabetes? Is this a problem of our cryopreservation method? So the main issue here are long-term developmental issues. However, this is a problem that we have after ICSI, a problem we have after extended culture, in short, a problem that we have after ART. And the main call that I would like to talk about this is that means that it's time for us to take the way we treat our embryos more seriously in general. It's not about forgetting cryopreservation whatsoever. And just as a controversial study showing other results, I want to compare with you, or show you a comparison between stimulated cycles and natural cycle IVF. So none of these embryos were frozen, and what you see is the ones that were subjected to less stimulation will have less prematurity and higher birth weight. So stimulation does play a role, be it from the endometrium, be it from the embryo, does seem to play a role on the birth weight of the child. As a short summary and looking to the future, there are many things that we need to look of threats and benefits. Many people are talking, however, about the potential advantage of a one-day freeze-for-all process, which would be the possibility that you could stimulate on any day, that you could use progesterone for downregulation instead of using your agonist or your antagonist, that you could easily convince or easily apply PGS or other omics generation methods, that you would no longer need to work on your weekends, that you would also potentially be able to do wild stimulation and get more eggs, and by some belief, more live birth. These, however, are all things that require validation. So my take-home messages would be, please don't run away from freeze-all. There is this new current showing that freeze-all is not good for anyone, not even for safety. My belief is that more and more people are showing that cryopreservation poses less risks than it does benefits, so the possibility should be further explored. However, it is very too soon to perform a freeze-for-all, and we better be studying better the kind of patients where we could apply beyond safety. Maybe with high progesterone patients, those with recurrent implantation failure, and those with a poor response. Thank you very much.